In your last lecture of the day, you addressed the worst case scenarios. And I love the title, right? What do you do when it all goes wrong? And, you know, what is the first step in trying to figure out what to do when a behavior case is just going down the black hole? And as a primary care practitioner at that point, I'm just imagining it's the end of the day. You've seen like 30, patients that day, and you almost like your head hurts. What's the first step?
For me, the first step is just don't panic. I mean, it's one of the things that I love about behavioral medicine. I'm not saying that there aren't emergencies, because there are, but most of our patients aren't actively dying in that moment. Like, there is a moment to pause and take a breath. And I just had the opportunity to share this with my team today. We were talking about emergency situations, and there's that temptation just to jump in and do something, like throw some trazodone at it or just do something. It's like, don't just the mindset, don't just stand there, do something. And it's actually the opposite, right? Don't just do something, stand there. Pause for just a quick second, say, what do I know? What does triage look like? What's the actual need here? I know you're worried about what's going to happen in 3 weeks when grandma comes. I know. Today, is there an immediate need that we need to be able to address? Is there a management solution? Is there a training solution? Do we need to trial it? Like, just refining what our actual goals are. So don't panic. Come back to what's actually necessary and doable in that moment. And then let's build off of that. Because we know for all of our clients, regardless of the complexity of the issue, if we give that client 37 things to do, or if we don't have clarity about what the ask is, we actually weren't all that helpful, or the client's not going to be successful implementing. So hit the pause button, get clarity, and then let's step forward with intention. And we'll talk about that as in so many other strategies when we get to the forum in June.
Chris Pockel's life lessons. I think I could use
That's what we
those
should call
life
it.
lessons. Yeah, seriously. Margaret, so I took my dog to a surgeon because I'm that mom. So I get a CT scan, as some of you already know, from nose to tail once a year on my dog, just because. So the surgeon did a physical exam and found pain. I was like, wow, okay, I'm expecting something big. Turns out that my dog just, was painful when he did that, but that didn't show up in the CT. And I've also seen the reverse. I've had cats in the meatloaf position. And I can't, like, are you painful? I don't know. You're not moving. So what is the best way for us to find pain in our patients?
Yeah, that's really a great question. I mean, I think the first thing is to pull out all the stops we can on our lower stress handling, right? Go ahead and use those pre-visit pharmaceuticals. We hear sometimes that, people worry they're not going to be able to find pain if the cat comes in on gabapentin. I would actually argue that you're more likely to find it if you're seeing more normal behavior. So go ahead, do all the things. And then I would say not to underestimate the power of observation. So we are all trained as veterinarians to be really good at observation. And I think we forget that sometimes, and we feel, again, like we have to do something. We have to move a joint. But spend a minute looking at their hair coat, their body posture, their muscle mass, how they're moving, how they're holding themselves. And don't underestimate the importance of that or how good you are at that. Then third, I would say get videos from owners in the home. I mean, cats with OA is something I think a lot about, so I'll use them as an example. We know that jumping up or jumping down or going up or down the stairs are behaviors likely to be affected, and they're also behaviors we are unlikely to see in the clinic. But if you ask people for specifically what you want, you can get a video that is short and quick and gives you a ton of information. I mean, the actual jumping up or down, that's fractions of a second, and it gives you so much more information than your whole exam might. So getting those in advance or asking people for those specifically so that you can do it in a timely manner. And then finally, sometimes we just have to use a pain trial. Sometimes we have to just say, well, let's see how your behavior changes if we give an analgesic. And then we can keep on the hunt. If it improves quite a bit, then let's figure out where is this pain. So I think those are kind of the big ways that we try to look for pain.
Our job is so cool Because one of the things
It
that
is.
I teach my residents, I know every single one of you, I don't even have to ask. I know you all teach your residents the touchless physical exam, muscle symmetry, nail wear, how they move, right? All of those things and more. Hyperextended hocks. Is the anatomy normal? Being a vet behaviorist is very cool because you have to know every piece and every part. Of course, I think it's the best job ever, but that's just me. So, Amy, Amy, one of your lectures is addressing fears and phobias, and the last statistic I read was a whopping 50%. I'm rounding up; it was really 49, but 50% of U.S. dogs have noise aversions. For me, this is pretty much on every differential list, probably for every dog that I see, right? So, you know, do you see a lot of cases where you think noise aversion contributes to those other diagnoses, generalized anxiety, aggression, et cetera, et cetera?
Absolutely. I mean, especially here in DC, because we've got, presidential motorcades going by and sirens all the time and helicopters and 3 different airports, with everyone's in the flight path. Like noise is huge here. Of Arlington National Cemetery, they do every Tuesday, they do cannon fire. Like it's everywhere. So we see a lot of it. And like Margaret said, we see so many patients where pain is an underlying contribution. And we know that noise phobias are worsened by pain too. And I think that's one of the reasons that we're seeing so many issues with noise phobias in our patients is because a lot of that is stemming from an underlying pain disorder, but it's huge. I would say it probably one of the noise aversions probably goes on almost every diagnosis list that I send home with a patient easily. And to be fair, I also think they're one of the hardest things to treat, especially in this area because of how just bombarding it is all the time.
For sure. Megan, when I see clients sometimes that have pets that cannot go to the veterinarian, we talk about options and pathways. How do you choose whether you're going to try to tweak oral meds for medical care to be done, or whether you're going to start down the path of trying to get that pet to be able to be, accept an injection for full sedation? Like, where's your tipping point with that?
That's a great question. And I always kind of talk to my attendees. Everybody has a line in the sand of where they say, okay, we're not going to get away with this with oral medication, so we need to move to sedation. And I think, again, depends on your procedure and if this is something that needs to happen today. My line in the sand is before I'm getting to the point of high arousal where I know my drugs are not going to work. So something has to be done today. My as we'll talk about, less is more approach to restraint, use of food for counter conditioning, mitigating the stressors in my environment to create this sort of Zen feeling of, this is a comfort zone, not a clinical zone for you that in the past may have been scary for you. And if I'm still seeing an animal unwilling to eat, I'm seeing dilated pupils, I'm seeing all sorts of stress signals like panting, pacing, yawning, avoidance, or any modicum of they might feel the need to reach for a defensive aggressive strategy to protect themselves, then I'm probably going to say, if we want this done today, our next step may be sedation. And it may be that sedation isn't even possible because that pet isn't in a place that they're going where I can safely and humanely administer that injection, because that's the other part of it. You want to make sure that you're able to give that intramuscular injection in a way that is not super scary for that pet or dangerous for you or your staff to give. So you may not have a choice. You may be sending them home to come back later that day if needed, because I need that adrenaline to go way down here if I have any chance of those drugs working. And typically when, I'll have veterinarians reach out to me for advice on, well, I've tried this oral med and this oral med and this oral med, and they tell me what's happening. And I said, there's no oral med that is going to help that patient. I think sometimes we just have to accept that. When you have such high arousal, when you have full sympathetic nervous system arousal, your HPA axis is through the roof at, basically you had me at hello and we're there. There's no amount of oral medication that's going to stop that. These patients are going to override all of it. So we have to make a plan for that ahead of time. And yes, we have to have that, veterinary patient relationship to legally be able to prescribe these medications. But there's some patients that every vet is fired, no one else can handle. So we do a little parking lot. Hello, hello, good to see you, VCPR, you're alive and breathing. Here's your trazodone, come back tomorrow, right? Because we don't have a choice. It's not safe to get that full exam. But, I think you go a long way of reducing. And maybe that's not just trazodone. Maybe it's trazodone and clonidine and gabapentin. Maybe it's polytherapy just to get you in the door to tolerate an intramuscular injection. And then we still have to be creative about, well, where is that injection? Is that in the car? Is it in the parking lot? How sneaky can we be so that that dog's distress about it is so minimized that they don't then retain that experience for every other visit? Because you could ruin, let's say you have a brand new patient, brand new client, you could ruin their entire veterinary experience from then on by having a really stressful sedation procedure. So the sedation will help you, but getting it in the animal safely and humanely is your first step.
Yeah, and I won't give away the secret, but Dr. Heron taught us a way to get the IM injection really quickly, which we use and we've expanded on and use all the time, but I won't tell you what it is. You have to come to the Practical Behavior Forum in Minneapolis. Yeah, it's good too. Dr. Christensen, or Dr. C, as the clients call you, one of your lectures that you're giving at the Practical Behavior Forum involves house soiling. And I remember Oprah saying something. She said, am I still talking about this 20 years later? This is how I feel about house soiling. Am I still talking about this 20 years later? This, unfortunately, is still a common problem, even though there's lots of good CE out there. So, what is the one thing primary care vets just have got to know about house soiling?
I'm a little oppositional defiant, so I'm not going to give you one thing, maybe two. One is do your medical workup. Just do it. And if the clients won't let you do it, okay, fine, treat behaviorally, but also maybe just treat medically anyway. No, I'm not saying just throw antibiotics at everything. That's absolutely not what I'm saying. But treat for the treatable where it's good for the world to do so, and has low harm, right? And the other thing I would say is just assume that cats are just being cats instead of being jerks, right? Cats just get assigned the jerk label all the time, and they're just cats, right? They're just doing their own species specific thing. Like many cats that are peeing outside of the litter box, to be honest, if that were my only bathroom, I'd pee somewhere else too, because their bathrooms are disgusting, right? So, but what I would say is, on a hopeful note, when I see a case of house soiling these days, I've been at this, I know I look like I'm 17, but I'm pretty old. So I've been at this for 20 years now. And the cases of house soiling that I get are always really hard, which I think means that a lot of really great cases are getting treated to remission successfully in primary care. So I think that actually we're doing better than we've ever done for house soiling cats. Because if we weren't, I would see a lot of easy cases like I did in my residency. It was you know what? Change the litter. Boom. Talk to me in 2 weeks. Call me a rock star and I'm going home. That's not my cases anymore. Now my cases, all of them have marking components. All of them have complex medical disorders. And all of them probably have litter box aversion and substrate preferences and location issues and noise phobias and pain, right? They're the kind of case I love, but they're not easy. So I think that our GPs are actually doing really well. And our families are where we need to do the most support, because I do still have clients coming to see me where, there are really bad things happening to cats because people think that the reason they're peeing outside of the box or on their cashmere sweaters is because they definitely know the difference between the cashmere sweater and the litter box and the rug and, a cheap t-shirt that's brought in from the garage. They know the difference between the substrate, but do they know how much it costs? I don't know. Cats are smart, but money's not their currency,
Yeah, I'd like to say my 16-year-old doesn't know the difference between the costs. So I think attributing a higher cognition to a cat, Margaret can comment, but I just don't think the cat is smarter than
What do you think, Margaret? Can we do an elevated plus maze? Right. Find out. How hard will cats work for money?
So everyone that came here today, Amy, Elise, Megan, Chris, Margaret, thank you. And I'm really excited about the Practical Behavior Forum. Another cool thing is that the Q&As are group Q&As. So the thing is, this group, we all know each other. A lot of us went to school together. Me and Elise went to school together. Me and Megan, been friends with Amy and Chris and Margaret forever. So the tone is comfortable, right? We all know how the other one practices. And these group Q&As that we're having 2 different times within the Practical Behavior Forum day are a time for you to get all your questions answered about anything, not just about that lecture, and a time to get all the different viewpoints. And because we all feel so comfortable, we'll speak up. There won't be someone who will feel silenced or intimidated, not in this group. So we hope that every single one of you that's interested in behavior will come to the Practical Behavior Forum best behavior conference ever. Thank you, everyone. Bye.
Good night.